Dr. Ghassan Wabe, who is the director of the Inflammatory Bowel Disease Center at Seattle Children's Hospital. He is the professor of pediatrics and gastroenterology at the University of Washington School of Medicine. Dr. Wabe's clinical focus is advanced care for children, adolescents, and young adults with Crohn's disease and ulcerative colitis, including advanced therapeutics and pre- and post-surgery IBD management. Dr. Wabe's research interests include advanced management of moderate and severe colitis in the outpatient and inpatient setting, managing complicated Crohn's disease, including fistulizing and stricturing phenotypes, mucosal hearing in IBD, navigating surgical options in IBD, and novel therapies. He is actively involved as teaching faculty in the medical student education, resident training, as well as fellow physician specialty training. And he has been honored as the Outstanding Teaching Faculty Award, as well as the Family Choice Award and the Northwest Crohn's and Colitis Foundation Service Award.
Welcome, everyone. I'm so honored to be asked to speak to you today. I don't get asked a lot of nursing conferences, but it's an honor always to talk to what I think is the most incredible group of providers I've ever worked with. Quick shout out to our IBD and GI nurses. And, Lord knows we can't run a GI clinic or program or service without nurses. So you guys make everything better, and we're lucky to have you. I was thinking about how to structure the talk for today. It's a primer on IBD, and I know some of our nurses are more outpatient, some of our nurses are inpatient. So I put a bit of a blend of, general concepts and then a bit of the map for what we do inpatient and outpatient. But at the same time, feel free to stop me, ask me questions. If you want to say a joke, if it's getting too dry, can't get too dry, please feel free to say a joke. That's okay. The reason why pediatric IBD became its own specialty is what you see here on these graphs. Not just the past 2 decades, but if you look back, from the time that we had better statistics, 40s, 50s, 60s onwards, we've seen a global trend in IBD on the rise. Some thought maybe it's us keeping better track of who is getting IBD, but it turns out it's actually a genuine increase in the incidence of a lot of these conditions, along with asthma and eczema and allergy, autoimmune conditions. And of course, that fuels a lot of hypotheses about why is this happening, and the idea that it's our environment changing. Obviously, our genetics could not have changed over a few decades by that much. Yeah, we probably need lots and lots, tens of millions of years to have a meaningful change in our DNA, unless the cosmic radiation event that changes everybody's DNA. And so the challenge here is to understand why we're seeing more of these conditions, but at the same time, get better and better at treating them until we're able to explain why IBD happens and how we can cure it. But IBD is really a pediatric disease because of this. The majority of patients with IBD will present between the ages of 10 and 20, maybe 25 to 40, 25 to 45. So it's a disease of young people, which has a lot of implications. First, when you give a child who is 10 or 8 years old symptoms that affect their, anything has to do with poop, in the bathroom, embarrassing symptoms, and stunt their growth, obviously that's a huge burden to carry going forward in their teenage years, and that carries also into their adult years. So a huge impact, and that's why we as pediatric pathologists have that window to try to get these inflammatory conditions that affect the rest of our patients' lives, get them taken care of well early on, so we can prevent some of the complications that could happen with time. So if you look at how many individuals there are in the United States with IBD, we're looking at about 1.5 million individuals. When you look at Seattle Children's and how many new cases we see per week on average, we're looking at probably 1 to 2 new cases per week. So about 50 to 100 newly diagnosed kids every year with varying degrees of intensity of inflammation. At our IBD center, we regularly follow a cohort of about 850 kids with IBD at any given time. And of course, once they hit age 19, they transition to adult. So now the billion-dollar question is, why does IBD happen? We know that it's on the rise. We know there are trends globally for increase in Crohn's and ulcerative colitis. And the question is, why? So one obvious question that is always interesting, which is the genetics that could drive any person to develop autoimmune or an immune dysfunctional condition. And what's interesting about IBD is we've found probably over a couple of hundred genetic mutations that could be associated with IBD, but this association has remained overall weak. And the best shining evidence that the genetic influence in IBD is limited is what we know from studies mainly out of Europe that looked at identical twins and the incidence of IBD in both twins. Patient has IBD, specifically Crohn's disease. If they have a sibling, identical twin sibling, the odds of the twin sibling having Crohn's disease would be about 35%. And obviously, if it's a genetic disorder, this would be 100%. It's also interesting because if you think about it, identical twins are kids are exposed to the same temperatures, probably same blankets, from constantly as my household goes, same, food with some variation in there. It just goes to say that, it cannot be pure genetic, it can't be pure environmental factors that cause IBD. So then the question is, let's look at the environment. Is it the diet? Is it high smoking habits in different parts of the world? Is it abuse of antibiotics? Is it how far we live from the equator? We know that research has shown that certain ingredients in the diet can actually deprive some of the local immune mechanisms in the gut to keep us separate from the microbiome that lives inside the gut microbiome than we do our own body cells. And so one simple example how diet could relate to the risk of IBD is diet hitting the membrane between lumen of the intestine and the intestinal deeper layers. And this allows the bacteria and the viruses and the yeast in the gut to get closer to the immune system and invade the wall of the intestine. So diet could play a role there. Research out of children's with Krugman showed that the use of antibiotics early on in life could actually set the state as a risk factor for developing IBD. Next, all of this ends up changing our immune system and how our immune system is reacting to the microbiome. So a simple way of understanding IBD conceptually is the notion of the immune system usually can fight infections. So there's a signal in the gut that there is an infection going on, and the immune cells head to the gut where there is that infection, and the fight against the bug, the immune system mounts this huge reaction, invites more immune cells, starts to produce a lot of chemicals that are basically digestive enzymes. So it's chemical warfare that ends up breaking down not just the bacteria that is trying to invade our system, like Salmonella or E. coli, but it destroys the area around the bacteria. And that's where ulcers are generated, blood starts to show up. So this chemical warfare of the good purpose, which is destroy the invading organism, but in IBD, it does not know how to stop. And that's one of the biggest challenges that we see, that the immune system is not able to stop itself when there is inflammation that does not have a purpose. In IBD, there's no understandable reason why the immune system gets revved up to this degree and intensity. There's no also clarity on why does the body find itself unable to actually stop this intense reaction. And there are data to show that on average, about 15, 20 years ago, it was taking a pediatric patient on average a year and a half to get to a pediatric gastroenterologist to get diagnosed, to get started on the right treatment. A year and a half. So part of our goal in pediatric gastroenterology is to shrink that wait time and lag time and get patients diagnosed very soon after presenting with symptoms, because we know there's a nice window that we can get much better results if we make the diagnosis way earlier. If you look at a child having IBD versus an adult having IBD, obviously children will live longer with IBD because as of today, it has no cure. We have to be very sensitive to whatever the inflammation cause, not just in the short term in terms of symptoms, but long-term complications. Our patients who are 5 years old with IBD today, are expected to live, through their, 80s, 90s and more. So I have to think about what could I be doing better today to make their lives better with when they're 85 or 95. That also means that whatever we treat our kids with today for long periods of time will mean that they're exposed to that medicine a lot longer than an adult patient. That means the risk of side effect also with the longevity of exposure to medication, but also the risk of some of the medications causing side effects specific to kids. If you look at steroids, which are unfortunately some of the most common medications in IBD today in adults and less so pediatrics, which should not be the case. Steroids, particularly in kids, could stunt the growth and have way major effects on the bone density and weakness compared to adults. I can't sort of go back and fix a child's growth if it's stalled, in the teenage years, and that's when IBD is presenting in 25% of patients, versus an adult who's taking steroids for a few courses when they're 40 or 50 or 60 years old. And it's also the challenge of testing, right? We talk about colonoscopies for kids, colonoscopies for 2-year-old kids or 3-year-old kids. So we have to be sensitive about the safety of these that we do for kids compared to adults. On top of that, if you look at the severity of IBD, the presentation is definitely more severe in kids compared to adults with IBD. I want to spend some time here to go over some of the signs and symptoms that we encounter. And we know that abdominal pain is the most frequent symptom the pediatrician would see a child for in their clinic. So, of course, the question is, when do you take that abdominal pain to a different level of seriousness and send that patient or suspect IBD? Abdominal pain, nausea, vomiting, diarrhea, or even constipation could be symptoms of IBD. And so, classically, we look at not just belly pain, but what else is going on with that child's complaint in addition to the belly pain. And fortunately, we have one of our best tools here at Pediatrics, which is the growth curve. So a child with belly pain whose growth is changing, not losing only, but potentially slowing down on the rate of their growth, could be a child with IBD. A lot of kids, 25% of kids, could have extraintestinal manifestations that give us hints or clues that this abdominal pain is more than just a little bit of constipation or gas or diet-related issues, but really chronic bowel inflammation, which is what IBD is. Of course, travel history. If somebody has been exposed to a bug, at a local fair, or parasites, if they travel to areas where parasites are common. Obviously, these infections are not as common in the Northwest as other parts of the world, except I'm reminded that the E. coli outbreak, one of the bigger ones, happened in Washington State. We have a child with symptoms. We've identified that the symptoms are a little fishy. Then we look for the physical exam. And we look again at the growth curves. We look at the height pattern, velocity. We look at the weight loss patterns. And then perianal disease. This is one of the big hints that a child has Crohn's disease. And surprisingly, or not surprisingly, a lot of teenage patients, again, where IBD, age of presentation, is dominant. If we don't ask about these things, if we don't look, then we could potentially miss a diagnosis of Crohn's disease in a teenager who has chronic abdominal pain. I'm going to show you some pictures about this. So this is a teenage patient who was 15 years old, and they've had abdominal pain for well over 9 months. And we asked about different diarrhea, no. Weight loss, no. This was a larger sized child, and some blood maybe with using the restroom. But it wasn't until I actually did an exam of the perianal area that I saw that this was severe perianal Crohn's disease. And we're looking here at the perineum. This is anterior, this is posterior, and these are deep Crohn's ulcerations in the bottom area. So this is Crohn's disease. Then again, if anybody had seen this child with a month of abdominal pain and you saw this, there's a 99% chance diagnosis of Crohn's disease. Other hints would be oral ulcers in a child with belly pain. They're not always as obvious as this example here. Sometimes inflammation on the edges of the mouth or angular stomatitis, plus abdominal pain, plus growth changes. That could be a good sign of having bowel inflammation. These are bruise-like lesions of the shins. called erythema nodosum. They present in multiple infections and chronic inflammatory conditions, and IBD is one of them. Unlike bruises, they appear without a history of trauma, and they could be pretty painful. So a child with belly pain and erythema nodosum, we will take that belly pain with a lot more seriousness and consideration compared to a child with just abdominal pain. Now, these are some of the extraintestinal manifestations that we could see in IBD. Again, up to 25% of kids with IBD would have joint inflammation, whether it's axial or central inflammation like ankylosing spondylitis, or peripheral arthritis like the finger involvement, maybe to a lesser extent hips and knees. Skin, I showed you examples of erythema nodosum. There are a couple of other types of skin conditions that are associated with IBD. Eye inflammation could happen, uveitis, episcleritis, presentation of eye pain and redness in the white part of the eye. We talked about the oral ulcerations that could happen. And there are patients with IBD who have liver inflammation or biliary tree ductal inflammation, known as sclerosing cholangitis. And they tend to have a very tough course with liver inflammation compared to the bowel inflammation. If this child might have IBD, then we move on to our standard tools, the blood test, the blood counts. Albumin is a good inflammation marker. Acute phase reactants that show inflammation like CRP and ESR. We have some fecal markers like calprotectin, which is popular. It's a good test, not a perfect test, can come in handy if you have a child with belly pain, chronic belly, not enough evidence to suspect IBD. You could run a calprotectin test to point you towards bowel inflammation. And then a few years ago, serologies or serum antibodies that are associated with IBD were popularized, but we don't see a role in those these days. So a particular subset of patients, kids with IBD, are particularly interesting and challenging in that younger the child is, so under 5 years of age, but particularly under 2 years of age, we start to see up to 15% or 20% of our kids under 2 having immune deficiency or a genetic mutation that is associated with IBD or IBD-like inflammation. And these are some of these disorders: chronic granulomatous disease, glycogen storage disease 1B, Hermansky-Pudlak syndrome, and IL-10 deficiency. And the unique thing about children with these specific immune deficiencies or genetic markers is that we know that this IBD is caused by this immune system abnormal behavior. And so we can cure this IBD type with replacement of the immune system, which is exactly what a stem cell transplant, successful stem cell transplant is. So these are unique patients, a unique subset of patients with IBD where the treatment is completely different and a cure is actually a possibility. My colleague and friend, Dr. Roche, says if you have an issue, you get some tissue, which is why we do colonoscopies and endoscopies. This is what Crohn's disease looks like in the stomach. I didn't elaborate into this, but Crohn's disease can involve any part of the gastrointestinal tract. Colitis, ulcerative colitis, is limited to the colon. These are ulcers in the stomach. This is the pylorus here. This is a picture of ulcerative colitis. The colon does not go with vascular markings. All these up here are erosion. And this is a picture of very severe colitis in one of our patients who was 7 at that time in the hospital. Again, you can't see any normal tissue. It's just very inflamed, swollen colonic mucosa with huge degree of ulceration. And this patient required a blood transfusion every few days. Crohn's disease, on the other hand, looks a little bit in the colon. You can see these deep ulcers. This is pus overlying an ulcer. There's an example of a deep ulceration here. And Crohn's disease involves all the layers of the intestine, whereas ulcerative colitis involves the insidemost layer only. So there are other tools that we can use to look at the middle section, which is the small intestine that we cannot read with our standard endoscopy and colonoscopy. And that's barium contrast study, ultrasound, CT studies, CT enterography, and MRI enterography. MRI is nifty because it doesn't involve any radiation, but MRIs are very slow. It takes about 40 minutes to scan the belly with an MRI. CT scan, you can scan the belly within 20 seconds, but there is radiation. A new thing that we introduced in our clinic is ultrasound, which is an amazing and easy way to look at the bowel wall. And we have a program at Children's. We're one of the few centers in the West Coast who use ultrasound to neurologists to study the bowel live when our patients are in clinic. Barium studies or fluoroscopy now is less popular. It's the same amount of radiation as the CT and doesn't give you as much information. This is an example of what we see with MRIs. This is the bowel here. The whiter part is contrast. And this is all bowel that should be paper thin. We're looking at a normal thickness of about 2 millimeters. And this here was about 1.5, 1.3 centimeters in thickness. Very, very thickened bowel. Another tool that we have is capsule endoscopy. So it's a capsule a little bigger than a big chunky multivitamin pill. Kids swallow it. Generally over 8 years they're able to swallow it, or we can place it with an upright endoscopy. It travels throughout the gut and takes about 4,000, 5,000 images, and then gets us a sense of what's going on, in this case an ulceration in the small intestine. And then it gets pooped out. And if you're lucky gastroenterologist, in your career, at least once you will see that capsule exit the body into the toilet live on the beam video, which I have been very fortunate to have witnessed at least once in my career. All right. So now we've suspected the diagnosis. We've made the diagnosis. What is next? We set targets that every child with IBD should meet when they are successfully treated. That's remission. Remission is using a lot of things across the past few decades, from feeling better to now all of this. A child with IBD in remission has no symptoms. They have no flares. Flares are breakthroughs in the inflammation. This child would have completely normal growth. This child is able to go to school. This child is able to tackle the same social and emotional challenges that any other teenage child face at this age. Now, deeper than just the feeling better parts, growing better, it's also that the demonstration that the inflammation itself is less. And that's by using biomarkers like the CRP and the ESR and the albumin, the CBC that we talked about, and also showing healing. So the ulcers, the example that I showed you in the slide, showing that these ulcers have healed back to normal on that is successful. All of this ultimately, hopefully, will change the natural history. In the past, we were looking at disease that damages the bowel with time. Eventually, kids get surgeries, scar tissue, fistulas, abscesses. And by treating a patient effectively and early, we are successfully seeing a change in how Crohn's disease behavior has become compared to a decade or 2 decades ago. We have clear definition of these targets. What is a normal calprotectin for a child with IBD, an adult with IBD as well? What is a CRP target? And these are lists that we look at every time we see a patient. We go through this cycle of we see a patient, we see them get better, or if they're not better, we go back, we confirm that this is active disease, we change the therapy, and then we assess our patients again. They're not doing well, we go back and do the same cycle. So it's never ending. We keep looking at our patients, changing the therapy plan as needed until we have stability and confirmation that the inflammation is controlled really well. And we continue the cycle for the entire duration that we care for our patients. It's not a year type condition. It's a see you 3 times a year or more and take care of what updates come up. The next part of my talk, so I know that we have about 25 minutes. I want to leave some space for questions. So I don't know if the chat box here. Again, feel free to ask me any questions, send them in the chat box. But I wanted to tell you a bit about our IBD Center at Seattle Children's. This is probably a project that we started. The vision was there, since I joined 19-ish years ago, and with the help of some wonderful colleagues, physicians, nurses, dietitians, social workers, administrators, and managers, and radiologists and surgeons, go on and on and on. We built our IBD center, which today is one of the lead centers in the nation and Canada, so North America. And we are a referral center for the region. It is about the diet. I actually refer to the diet next, and I will get to that question. Yeah. So what is our IBD center, and what does it look like? We have our IBD clinic. IBD clinic is staffed by an IBD provider, an IBD specialized nurse. We have support from our MA. We have access to our dietitians, our social workers, and we offer it in different locations and through telemedicine. We have forwarded patients in Juneau, Alaska, Ketchikan, Alaska, and Anchorage. But we offer also our services as second opinion for essentially all patients, all comers from all over. I know my colleague, Mr. Tuscan, who's focused on this specific IBD diet, has found referrals from New Zealand, England, and beyond. So we're busy, really going. We also have our inpatient service. Most of our GI patients who are admitted have IBD. So we have dedicated to developing our inpatient IBD care. We have a very powerful IBD research program that is looking at the massive stages of IBD from very early onset IBD, cellular behavior in IBD, microbiome, nutrition, including the SCD and IBD. We are on for clinical trials for new medications for kids with IBD. And we're looking at imaging, we're looking at transplants, transplant crossover, medications and crossover with IBD, and a massive extended here of IBD-focused research. We also have an education arm where we try to reach out to the Crohn's Colitis Foundation, through the Crohn's Colitis Foundation to our patients to be involved in patient education. We're connected with our infusion services, children's inpatient and outpatient. And we're closely associated with the Crohn's Colitis Foundation and with the Improved Care Network, Improved Care Now Network, which is a collaborative across over 90-some centers now in the world, tracking data for IBD patient care. That's our IBD Center. Our vision is to provide the best care humanly possible and to integrate novel therapies and to understand the reasons why IBD happen and how can we treat it better. Easily and over what our IBD team looks like. These are the core members of the IBD team. We cannot work without each other, to be honest. And we've always thrived on improving our services and our team with everyone's input. Part of what we do is we meet every week with rare exceptions throughout the year. We review our patients who are in the hospital. We review any candidate cases from clinic. Beyond that, they can be counselors. For some of those kids, it was be the first time away from home, and the experience of being a kid there to have fun among a group of kids who actually know what IBD is has been life-changing to a lot of our kids. So it's part of what we believe, and I personally believe, is duty to support our patients and be there for them. And this camp has regularly been staffed by our physicians and our nurses with some help from our colleagues from ophthalmology practices in the community. These are the key principles in how we treat IBD. Diet is a huge part of what we do. We perhaps say as a team, we successfully avoid steroids in approximately 50% of our patients, which, if you think about 5 years ago, is unheard of. And we take great pride in the fact that we go the extra mile to try to avoid using steroids altogether. I want to spend 5 minutes on this. Having through training and now 19 years of practice, it's been absolutely stunning to see how scientific development brought so much new energy into providing better therapies. And I'm fortunate to be able to see that stage of development from way, way early stages of development of a treatment, including the use of different dietary therapies, to what I can offer my patients today to get them to feel absolutely great. And so remember, we talked about how the pathology seems to be the interaction between the immune cell here and the microbiome, and how the intestinal cells lose their effective defense mechanism. And then we have the inflammation cells that are just super active and not able to calm themselves down. So these are some of the target molecules. TNF molecule for a lot of, I'm sure the audience who have kids with IBD or have worked with our kids with IBD in patients or in the treatment area. TNF molecule is one of the molecules that feeds the inflammation. And this is targeted by medications like infliximab or adalimumab or certolizumab, golimumab. Beyond it, there are different targets, like, for example, this receptor here on the immune cell that is triggered by the TNF molecule. And we have a newer medication. We're running a clinical trial now with this medication called tofacitinib to try to block this interaction between the signal and the immune cell to prevent it from becoming active. And other targets here, IL-12, IL-23, IL-10 disorders that could be actually cured with a stem cell transplant. And again, every 2 years, there's something new coming up. This is an interesting medication that we have a clinical trial with, and a lot of patients are getting it already, called vedolizumab, which prevents the movement of the immune cell into the tissue. So it blocks it, and it's selective to the gut. It doesn't do anything outside of the gut, which is also a safety feature. Just for interest here, I've listed the medications that we've had essentially from the 50s: steroids, azathioprine, sulfasalazine, and how over time we progress to newer and newer targets of inflammation and therapies. And again, just for completion's sake here, a list of all these medications that we have today. The key word here is key figures, or effective therapy. That's exactly what we want to do. And without going into too much detail about what that means, we're using our better treatments, including diet, up front, instead of in the past using some weaker treatment, try this for 3 months, try that for 3 months. The approach now with Crohn's disease specifically is to start our best and most effective medications up front and not delay them till later. And nutrition therapy is critical to every child's treatment. So I know a colleague asked about diet therapy here. So it turns out by altering the diet some way, and it almost doesn't necessarily mean what type of diet, but if you change somebody's diet and have them limit what they're eating and drinking. So sometimes we use, over-the-counter shakes, just these, regular shakes. Although these shakes are very high in carbohydrates, they're not really wonderful nutrition, to be honest. But the idea of using them has been proven to reduce the immune system's overactivity. And it's because we think that the immune system is so operative that reducing how many variable proteins the immune system is exposed to in the gut seems to actually lower its activity. And it seems to be as good as using steroids to treat the inflammation or make patients feel better. More and more studies have shown that diets that exclude very highly processed foods, refined sugars, gluten, lots of grains, that's what the specific carbohydrate diet is, was really effective in reducing the inflammation. Dr. Susskind, my wonderful colleague, is a pioneer in the world with pediatric-focused diet therapy using the specific. He has amazing videos, by the way, with recipes for the SCD that I love watching. I highly recommend. So this type of diet can actually lower the inflammation. What we don't know yet is if the SCD on its own is enough to get the inflammation to that deep level of remission. Remember what I told you about what remission looks like? We need not just to help our patients feel better, inflammation get lower, but we want to see complete healing. And this is one area where it's not clear if diet therapy on its own can address this. So at our center, we actually use the best of all worlds. If anything's going to help the patient, we have integrated that, including diet therapy, like SCD, there in the management plan. Now, there's very, very mild, occasional mild disease, which is not common in children, where you could actually take up the inflammation with the specific carbohydrate diet. And as long as the specific carbohydrate diet is well-rounded, and that's why we have the help of amazing dietitians who are expert in the specific carbohydrate diet, as long as the diet is well-rounded, it covers the nutritional needs. We've had research out of children to study what are the deficiencies on the diet that could be easily managed with vitamin and mineral supplementations. Then the diet could be continued very long term. And the endpoint here is not staying or not staying on the diet. The endpoint is, do we have deep remission that includes deep healing of the baseline inflammatory lesions that we have seen? So I hope that answers the question about the STD. Another question I have here was, do we see fevers with severe abdominal pain on and off? Yes, we can, absolutely. And there are other conditions that give you high fevers with abdominal pain, but the problem with fever, recurrent abdominal pain, is a child I would consider, among many reasons, I would consider IBD as a cause. Another question is about transition. I cannot type as fast, but I'm going to type all the link to that CD diet. Check out, I think it's thimble.org, or if you just Google thimble. It's a fantastic website developed by Dr. Susskind with a lot of recipes there and links to other websites. Transition. So the question about transition is interesting because it's one of the areas that we still, I don't think, do a great job at. This transition period is, of course, scary because our pediatric approach to handling patients and families, communicating with the child and the family, adapting our communication style and treatments based on the child's age and maturity and development. So it is a bit of a shock with the transition. There are different models that have been proposed with that transition that I think have been talked about and published about, but have yet to prove themselves practical. The best tool that we found so far, and I credit our nurses in IBD clinic, and Teresa Locks and Sarah Bondi and Sarah Buck and Jen Neckerman and Melanie Dean, and again, I could go on and on about that treatment, and of course, Raquel Foreman. And go on and on and on about their role in making this process as seamless as possible. The biggest value here that we had was actually educating the child as they are growing, how to answer their own questions, how to speak up for themselves, how to start refilling their own medications. And I still think it's one of those bigger challenges that stay resolved as of now. This is a brief summary of what part of our work is, which is developing standard clinical work for acute severe colitis, our kids who come in with very bad ulcerative colitis. Our kids come in admitted with Crohn's related abscess and how we manage that. And I wanted, in the last 6 minutes here, I wanted to close with this. I think I've held on to this painting now for about 17-ish years. And back then we had this project called Crohn's in Color. And what we did through the Crohn's Colitis Foundation is we presented a number of our kids with IBD canvases and brushes and paint, and we asked them to paint their IBD. And one of my very talented patients, former patients, drew this, and when I asked her about what things meant in her painting, she talked about the here being her very owy intestine and the raindrops showing her tears, and the lightning here was just the spikes of pain that she was having. And I'm just beyond proud and delighted to say that this particular super talented patient is a nurse, and just one of those amazing stories that give me a lot of optimism and pride and humility, honestly, in how resilient kids with IBD turn out to be, and how much difference they are likely to make in the world with all that they carry with their experiences of this disease. And again, one of the main reasons why we're all motivated to do better by our patients. So this is my last slide here. Thanks for sticking with me. I hope I didn't lose a lot more attendees to the headache talk, which is equally important. I don't dismiss headaches here.
No, thank you so much, Dr. Wabe. It was absolutely great. There's another question if you'd like to answer. Any recommendation for future diagnostics should someone in remission have another episode in adulthood?
The Johnson phenotype, where IBD goes up in childhood or young adulthood and goes into a quiet phase for a while. Very, very few adults could have that either one-off inflammation called acute self-limited colitis, but some might have a dwindling active disease for a while. And what we recommend today is that if there's a question about prior history of IBD since it's getting better, I still think that as of today, a good set of blood tests, a stool test maybe, but still endoscopy and a colonoscopy is still absolutely helpful to assure that individual that, yes, there is inflammation, it might be mild, but here's how you need to monitor it, watch it, or that there is no inflammation and this is truly a one-off thing. And it's one of those, I think, conditions where there's a lot of, providers can actually be okay not digging deeper into IBD, or you could, as we have done in our center, specialize in IBD and live and breathe IBD and provide an expert opinion. So I would say in these cases where it's not a classical story, it doesn't follow a typical pattern, seeing an IBD specialist can go a long, long, long way. And we're allied with several wonderful adult colleagues in the community who, what I tell my patients when I refer them to these colleagues is these are colleagues I would trust with my own family members, who have IBD. And so I think, having an expert opinion on this, likely some hands-on investigations would make a lot of sense.
Great, thank you. Let's see. Probably have time for one more question. What do you know about Entyvio used for Crohn's?
In pediatrics, we actually are with the team running the clinical trial for it. Although we've used a rule at Children's, IBD centers, if a patient needs a medicine and it's available in the universe, they should be able to get it, approved or not approved. But we're running the clinical trial for vedolizumab to hopefully get it approved for kids. It's excellent medication for moderate colitis. Does the job nicely, safe, has a nice safety profile. It's intravenous, and there may be, I don't know if it's near future, but future injectable forms available, which would be really helpful.
Awesome. Thank you so much, Dr. Wabe.